Dear ESTS members and webinar attendees, my name is Lymph Petersen. I am your ESTS webinar coordinator and moderator for today. This is the 8th and last webinar of 2018-2019 series. Today will be about the role of simulation in thoracic surgery education and is sponsored by Medtronic. I'm very proud to introduce you to Professor Rene Petersen as a guest speaker. Professor Petersen is Chief Thoracic Surgeon at the Department of Cardiothoracic Surgery at Copenhagen, at the University Hospital in Copenhagen, and he is Clinical Associate Research Professor at the University of Copenhagen. He's an international expert in minimal invasive thoracic surgery, and he has led many vexillobectomy training programs. Because of his special interest in and many scientific publications on education and simulation in thoracic surgery, he is the man who can tell you all about the role of simulation in thoracic surgery. Mr. Petersen, please, the stage is yours.
Thank you very much, and thank you for this privilege to share our research and our point of view on simulation. So first of all, I want to hear, can you see the slides?
Yeah, that's perfect.
Okay, so the topic today is the role of simulation in thoracic surgery education, and I have these relevant disclosures. So first of all, I would like to ask you all a question. So how many procedures do you consider mandatory to be proficient in performing vexillobectomy at your unit? 25, 50, 100? Or is it not dependent on numbers, but dependent on assessment by superiors? Or is it dependent on the use of assessment tools? So I would like to you to answer this question, and then we will come back to this after the presentation.
Okay, maybe for the people who didn't work with this yet, in your right sidebar, you have three words being questions, polls, and people. And in the polls, you can find this poll. How many procedures do you consider mandatory to be proficient in performing vexillobectomy at your unit? So you can vote. And we can come back. Indeed, we can come back later on this topic. Okay. Already, yeah, almost 10 people voted. So it started. Okay.
Great. Can I continue?
For sure.
Okay. So how do we acquire surgical skills? Well, almost 100 years ago, William Halsted was a pioneer in surgical training. He introduced the residency program in United States using the apprenticeship model, which has been the way we've been training surgeons for almost a century. So the idea of the apprenticeship model is that the surgeon work with an experienced surgeon. He assists the experienced surgeons or several experienced surgeons for a longer time to see the steps of the procedure, to learn the techniques from the master. And gradually, the training surgeon performs steps of the procedure. And having learned all the steps of different procedures, he or she will start performing surgery, but with the experienced surgeon by the side, supervising the surgeon. And when the surgeon has sufficient skills, you will perform surgery independently. And I think most of us was trained that way, especially in my generation and older. The apprenticeship model is effective and has been effective and has some advantages, but there are some demands to efficacy of the apprenticeship model. So you are reliable on a responsible supervisor, so a supervisor that is patient, who will learn you the tips and tricks and share his or her experience, and will be patient when you perform the first steps of the procedure, because every surgeon is slower in the beginning. So it is time consuming, and this is maybe a downside to this model. It requires time, and this is sometimes can be very challenging when there's a lot of surgeries on the list and people want to get over with the list. It is time consuming to train surgeons. Another obstacle may be that it is very subjective. So if the supervisor and the trainer get along very well, it can be very beneficial. But if they don't like each other, it can be a real struggle. And so a basic for this apprenticeship model is that learning happens automatically when you are exposed to a certain number of cases. I'm not so sure that this is applicable for all surgeons, but this is the idea in the apprenticeship model. Talking about limited time, we all know the expressions see one, do one, teach one, which implicates that there has not been enough time for training. So things may be different than 100 years ago. Today there's an increased focus on patient safety. And performing a procedure for the first time without sufficient training is not acceptable in today's surgery. We all know this Swiss cheese model. So when several things are wrong at the same time, major mistakes may happen, like surgery on the wrong side or major intraoperative catastrophes. Talking about vasculobectomy, this is an example of what can happen during vasculobectomy. This is a lower lobectomy with an injury in the pulmonary artery on the back side. And I think this is one of the main reasons for the hesitation in the early 90s when vasculobectomy was introduced. Surgeons were afraid of injuries to the pulmonary artery and were afraid of their patients dying from the surgery. Another major concern in the beginning of the 90s and maybe 10, 15 years from there was the concern about oncological efficacy of a vasculobectomy. So this is an example of a lymph node dissection in the right lower lobectomy in a stage 2 patient. For many years, it was considered vasculobectomy was considered only for early stage patient, and there was concern whether you could perform a sufficient lymph node dissection. This is the superior mediastinum. You see the azygos vein. You see the SVC with the phrenic nerve, and you see the subclavian artery. A bit of fatty tissue is left there where the recurrent nerve goes along the subclavian artery. So this is an example of how to perform a lymph node dissection with VATS. So how do we train our surgeons? So we are in a computer area, and the majority of our younger trainees have had a PlayStation in their house when they were kids. And what we see in our institutions is that the young surgeons, they adapt the idea of minimal invasive surgery much faster than in my generation. This was one of the first study a few years ago, it's almost 10 years ago now. It was published in the British Medical Journal from our hospital, a gynecologist who were looking into a newly developed virtual reality simulator for gynecology, and they compared the novices trained on the simulator to that of intermediate experienced laparoscopists in real OR, and they could see that compared to the novices without training on the simulator, they were able to bring these novices who trained on the simulator to the same level as intermediate experienced laparoscopists. And this was a randomized controlled trial, and they advocate simulator training. And this was published almost 10 years ago. So, how many, what kind of simulators do we have available for training? So there are two types of simulators, which is important to understand. So there are the black box simulators, which can be dry lab or wet lab simulators. And then we have the virtual reality simulators, which are computer assisted. So this is an example of a very simple black box simulator we use for research. You see just a box and a few instruments and a screen, and you can practice very simple exercises like this one, where you put the needle into some circles, and so you can have the surgeons training with learning the fulcrum effect, training with instruments, and doing these very basic procedures, putting these straws into the glasses and so on. Very simple models. Then you have much more experienced models, like this simulator developed by Thomas Stupnik. This was presented at the ESTS and will be presented again this year at the ESTS Training Village. It's a more sophisticated black box trainer with a screen and with a silicone lung, which will enable you to use the instruments you use in real life, like staplers and advanced energy devices. So when we look at these black box dry simulators, they are generally affordable. They're easy to set up. It's mainly for basic training, but there is the opportunity for training at flexible hours or after work, after hours in the hospital. You can have it in an office, and you can, in the more sophisticated models like the Stupnik simulator, you can exercise the use of staplers and advanced energy on these simulators. Then there is the wet lab simulators. So the most used model for this kind of training is the living pig, and this is an example from Miguel Tede from Brazil, who uses this model for the ear card courses. This is a drawing to show how he puts his 3 ports on the pig, and this is living tissue, so you can simulate bleeding. The pig is a very difficult model, and it's a very sensible animal. It doesn't tolerate so much bleeding, then the pig will die, and a part of the exercise disappears when you practice on a dead pig. The pig lung is very long, and the intrapleural cavity is very narrow. So it's a very difficult model to do a vasculopectomy. I would definitely say if you can do a vasculopectomy on a pig, you can certainly do it on humans as well. But it's a very good model. There are some downsides, though. It is expensive, and it requires a complicated setup. Then there are ethical issues with animal models. It enables advanced training. Again, you can train the use of staplers and advanced energy. You can practice vascular injuries and how to repair vascular injuries. And it's very suitable for courses, and it definitely needs an instructor. So the sheep model has been used occasionally, and it is a better model. It has better similarities to the human lung, but again, it's even more expensive than the pigs, and very few courses are using this model because of this. So a few years ago, we approached several of these companies who did laparoscopic simulators and tried to persuade them to develop a simulator for VATS. This was not easy because thoracic surgeons are a small group of surgeons worldwide, so the market is limited compared to laparoscopy. But Surgical Science developed a simulator with help from the unit in Copenhagen, the standardized interior approach. And the first model of a right upper lobe lobectomy was presented at the ESTS meeting in Copenhagen 5 years ago. This model has since been developed, and we have done validation studies on this model, and we're able to validate the simulator, so it could differentiate between novices and experienced surgeons, and we were able to establish a pass-fail criteria with acceptable consequences. This is an example of the very detailed information you get from a virtual reality simulator. So when you look at this chart, you can see that there are grades for every minor details, like stretch damage to the vessel, correct division of the bronchus, correct division of the fissure. Were there a blood loss? How much time was the procedure? And especially, I like this one where it measures the instrument pathway length. We all know that experienced surgeons, they know exactly where they need to go with the instrument, so their pathway is very short, where a training surgeon is not so straightforward in his movements and has a longer pathway length. So we are able in this way to have very detailed and objective information about how you actually perform. So this is a video of the right lower lobe. Again, we use these peanuts in real-life surgery. So we try to create a scenario that looked like the real-life surgery as much as it was possible. We recommend to sling the vessels, especially in the beginning of the learning curve, to make an easy introduction of the staplers. And here you see that it's the superior vein that is slinged, and a stapler is introduced. And again, the surgeon needs to choose the right cartilage. In this situation, it's a tan cartilage for the vessel, and the superior vein may be divided. The simulator we can enable small tips and tricks for learning how to do these steps. And so the next step is the superior trunk, as you see here. And now the superior trunk is divided. The fissure, the horizontal fissure is divided using purple cartilage. And there you see, if you make mistakes, it is obvious. And
nice simulation.
And so the rest of the tissue is divided and the lobe is removed. Of course, this is in its infancy. This was the model of the right lower lobe. For the last couple of months, we've been working on a model containing all the 5 lobes. And this is almost finished and will be presented in the training village at the ESTS meeting in Dublin, where I hope to see all of you. And again, I want to say that this is a process, and we need the companies to invest in this to get these simulators more and more sophisticated. It's of course it's not the amount of customers that you have for FIFA 2019, but I'm sure we will progress in the coming time. So overall, virtual reality simulation, it's expensive. It's expensive to buy the simulator and the software. Once you got it, it's easy to set up. It's good for basic training, and for now, basic to intermediate training. That is the level. I think we can, with better software, we can increase the audience, and it can also be interesting for more advanced surgeons, but this needs software development. It has the advantage of training at flexible hours. And then this is a model that we have not started yet, but we plan to produce is a model with an injury to the pulmonary artery. And in this way, we can exercise surgeons on how to cope with an injury to the pulmonary artery. And this is the advantage, I think, of a computer setup like this. And we'll also have the potential to, in the future, to have very difficult cases like pancreas tumors and other difficult cases that you're able to practice on the simulator. And then I think a very important point is that you get an objective assessment. Talking about assessment, we're in an area where it is very important for the safety of patients that we have that we can assess the quality of the surgery performed and the quality of the surgeon. So, first of all, to start the procedure, you need to have the theoretical background. We developed this MCQ test on the theory of performing a vasculectomy and published this in 2014, and were able to validate this MCQ that's available in this publication. So the next thing was to develop an assessment tool for evaluating the surgical competence in vasculectomy. And in this publication, we used an expert panel of international recognized vasculectomy experts that you see on this slide. And we used the Delphi method of distilling 44 items into a final assessment tool containing 8 items in 4 rounds, reaching consensus on these 8 items. So this is the scoring chart, the assessment tool called VATSAT. And as you can see, the topics are localization of tumor and other pathological tissue, dissection of the hilum and the veins, dissection of the arteries, dissection of the bronchus, and the lymph node dissection, retrieval of the lobe, respect for the tissue and structures in general, and technical skills in general. And so you get an overall score from 1 to 5 on the 8 items. So 8 being the lowest score and 40 being the highest score. And this is to show you how we support the assessors, how to give the grades. So you can see if the trainee handles instruments incorrectly and with too much force, does not keep instruments in the field of vision, is not familiar with most instruments, and lack fluidity and accuracy of hand movements, then you will get a 1. We tested this assessment tool in a nationwide study in Denmark. We had one of our surgeons traveling to the other 3 units in Denmark, recording 60 videos of vasculectomies performed by surgeons at different experience level. We had beginners, intermediates, and experts, and we were able, with this assessment tool, as you can see, to discriminate between beginners, intermediates, and experts. So experts were more than 500 vasculectomies. 50 to 500 was intermediates, and there was a significant difference in performance, as you can see. And we used the contrasting groups method to calculate a pass-fail standard. So to pass the test, you needed more than 31 points. Actually, there were 2 experts who failed the test, and there were 1 beginner who passed the test. But we were able to prove validity evidence using Messick's framework for VATSAT in a real-life situation with real-life vasculectomies. We did the same study in a modified form because we could not have retrieval in an endobag and lymph node dissection in the simulator. But we did the study with 6 items on the simulator and was able to validate VATSAT tool for a simulator setting as well. So in conclusion, we propose a mastery training program in vasculectomy as the following. So at the beginner level, we can test cognitive skills with a theoretical multiple choice test. It's previously developed and validated. And second, I believe it's important to expose young surgeons to virtual reality simulation for vasculectomy in the very initial trainings, based on the studies that demonstrate that you can increase the competence from a beginner level to an intermediate level. This is a safe way for our patients that surgeons can get familiar with how to use the instruments, how to work with the screen, to get all these basic things, to get them on board before you start performing surgery on real-life patients. So next step, step 3, is to perform minor VATS procedures like liver biopsies, pneumothorax, wedge resections, and so on. And these should be supervised by an experienced VATS surgeon. And in this phase, you will become familiar with board placement and instrumentation. And then we actually developed an assessment tool for wedge resection, where you can assess the competence before you start your surgeons at the next level. So when they reach this intermediate level, they can progress to learn vasculectomy supervised by an expert. And here we advocate a stepwise introduction to vasculectomy, again to be safe. And with the validity evidence provided for the VATSAT, we can assess competence, and this may aid the supervisor in giving a structured feedback to the resident. So using the VATSAT tool, we can target our training to where the scores are low, and we can train those specific areas of performing a vasculectomy. And finally, I think that when we assess surgeons before they are allowed to work independently and perform vasculectomies independently, we can combine the VATSAT tool with the assessment of supervisors. I still think it's important to have the human factor and have the supervising expert certify that now you're ready to perform vasculectomy by yourself and you have sufficient skills. So I've had the question many, many times: how many procedures do you need to perform to be proficient? And we'll come back to this in the discussion and the questions later on. But I think this is very dependent on the surgeon, the skills level of the surgeon, and the experience level. And the potential clinical implications for patients and the society and lower morbidity and mortality for lung cancer patients is promising in my point of view. So this was all for now, and thank you very much for listening.
Thank you very much. Very interesting talk. I think we will definitely have some questions. We were with a very small group today. I counted 38 people. I think the rest will be watching this later on. But maybe we'll come back to the first question then. The question you asked in the poll. And that was, how many procedures do you consider mandatory to be proficient in performing vasculopectomy at your unit? And there I see that not even 20 people voted, so maybe some other people can vote in the right sidebar. In the meantime, if you have any questions, you can ask them in the bar with questions, but maybe you can already comment on the first poll, Professor Petersen.
Yes, so I'm not surprised that 50 is the number that we've been saying for many years, that it's, you know, it's a nice round figure. You do 50 cases, you're proficient. But I'm surprised to see that almost 30% are using assessment by superiors or assessment tools, which I think is great to see that we've moved away from a certain number of procedures to be proficient. So I'm sure we'll come back to this. And actually, I would like to ask the next questions below. So how many vasculopectomies did you perform under supervision before you did your first case alone?
So you can also vote on this one. I hope people can read this because I don't have any. Yeah, we start voting. Perfect. Only 4 people awake. More coming up.
Well, I may comment already now because maybe it's a bit premature, but it's interesting that we all think that, you know, 50 may be mandatory to do vasculopectomy, but so far none have done more than 50 before they did their first vasculopectomy. And I think this is reflecting very well what we say and how real life is. And I think this is really interesting with this poll that we can get an idea about how is training in real life actually. And I think this is reflecting very well. And it's a few people answering the poll, but still 2 people have done less than 5 before they did their first case. And I think that's interesting. And I think we can do better. And then the almost the same question, but this time, how many vasculopectomies do you consider mandatory to be proficient in performing? Oh, sorry, that was the wrong one. Where is it? How many vasculopectomies performed under supervision do you consider necessary to be proficient? So there are almost half the surgeons saying that less than 20 is sufficient. And only one with more than 50. Okay. Then I have the last questions. The question is, would you offer your resident simulator training if it was available in your institution? And by this I mean virtual reality.
Mm-hmm.
And not surprisingly, I think it's a question of availability. We need to make sure that training surgeons are exposed to simulators, and the more expensive ones, like the Sputnik simulator, will be presented at the ESTS village, and surgeons will have opportunity to train in the training village. So will the lab sim simulator will also be available for people to train. And I think that we can consider how in the societies, the national societies, how do we promote simulator training. And one of the ideas could be to have one or two society simulators in a truck that you go from unit to unit and maybe let the truck stay for like a week for all the surgeons to train on the simulator. This is one idea of making it accessible to more people. So I was wondering, is there any questions? Let's see. So which one was first?
The one below was the first one that we spoken. So how many hours of work do you recommend in the simulator to acquire your skills?
Yes, that's a very good question. I don't have a fixed answer to that. Again, I think it's very dependent on where you are in your learning curve. But the advantage of the simulator is that you will get a grade. Once you've done a lumpectomy, you'll get a grade in percent, like 60%, 65%, 70%. So I would say when you do 100% in all 5 lobes, you've spent enough hours. But how many hours you need, it's difficult to say. Maybe one surgeon will need 100 hours and another will need 10 or 15. I don't know. I think that's really what is key in my lecture, is that we learn at different pace. And because you are a slow learner, doesn't not mean that you will not be proficient. I think some learn very fast, others learn slower. But what matters is the level you reach, and whether you are capable of constantly developing your surgery, refining your surgery. When we talk about learning curves, I think that we are all surgeons on a learning curve for the entire life. It's a troublesome learning curve in the beginning, and then you reach a plateau level. But I think we can always improve, and whenever we start doing new procedures, we begin with another learning curve. When I look at my learning curve in the beginning for vasculectomy, it was to perform the vasculectomy. Once I was proficient in performing vasculectomy, the next task was to perform a systematic lymph node dissection with, the proper way to get all the fatty tissue, all the lymph nodes. And this actually required more procedures and more training after I felt I was proficient in vasculectomy. And after this step, the third step for me was moving to secondectomies, was opening a new world, learning the more detailed anatomy. When we get to the second level of the anatomy, there are more anatomical variations. It's more complicated to do secondectomies. So this is the travel I've had in my learning curve. I think, we should be open for learning every day. So let's take the next question. So where are the European centers with simulators to get invitations and go there? I'm working uniportal, unfortunately only endoscopic decortications and atypical resections. So again, I would say come to the ESTS meeting for the training village. I'm sure that there will also be opportunity to train on the uniportal cases in the training village. That would be my recommendations for now. Next questions. The lab simulator is quite expensive. How do you suggest we get about funding to purchase one for trainees in our unit? Well, of course, there are grants from funds that you can apply for. But I think that the way to go is probably through the National Society. To get awareness in the National Society and maybe have some simulators for sharing. And of course, then you may need to travel, or if you have a mobile unit that you can bring to units, that will be a compromise, I think.
Mm-hmm.
And so the next question is, how many lymph nodes do you remove on average by lobectomy? I don't have a certain average number, but I would say around 15 to 20 lymph nodes is normal. This you have to be aware, counting lymph nodes requires that you take out a unblocked lymph node dissections, a paquet of lymph nodes. Otherwise, your pathologist will have no chance to measure the number of lymph nodes, because he or she will be measuring pieces of lymph nodes, and this is impossible to put the pieces back together. So you need to do a full lymph node dissection with an unblocked lymph node dissection. So that's usually what I advocate, is a full lymph node dissection, removing all the fatty tissue and lymph nodes in the subcarinal area and the superior mediastinum, station 5-6 on the left side, and the station 8 and 9 along the part of the subcarinal. I think it's the same question.
If anyone else has some questions, please shoot. I had a question on the assessment by the teacher. You talked about the apprenticeship model, and there it is the teacher himself, the surgeon, the experienced surgeon who does the kind of assessment. How does it work here with your VATSAT score? Is that another one? Another surgeon taking this score, or is it the same surgeon that did the teaching during the procedure?
So yeah, that's a very good question. So what we did in the study actually was that we recorded the videos, and some of these surgeons were actually supervised at that point by a more experienced surgeon. But we recorded the videos anonymously, and then we had 2 independent assessors who were VATS experts rating the videos without knowing who performed the videos. And actually there were 2 of the experts who failed, who had 30, and the pass-fail ratio was 31. So they actually failed, and one beginner who passed the test, he had 32. So I think this is the great advantage of this assessment tool, is that if you are trained with a supervising surgeon, actually you can record a video of your surgery, you can give this video, or the experienced surgeon can give this video to another surgeon who doesn't know who this is, and you can have an objective assessment. And I think that you will be surprised that when you use objective assessment tools, that focus may be something different than what you have experienced with your supervisor. I think we are subjective. So if you like your trainee and you have a positive attitude, you may sometimes not see the small mistakes that you will capture in when you use an assessment tool and a blinded assessment. And I think that's a major advantage.
How do you see this in the European exam in the future? Because this exam is only theoretical. Should we assess also the practical skills?
I think it's obvious that we need to do this at some point. It's complicated.
Because now we have just a logbook of how many procedures. How many procedures did you do? How many did you do well or not? That's not the question. It's just how many procedures.
Exactly. We are very number of procedure based. Well, I think it can be difficult with videos because people can cheat. So you really don't know whether they actually did this surgery or not. So I think that will be very difficult to control in an exam situation. But I think when the simulators become better and better, I hope that we can use these simulators for credentialing. Like for pilots, you need to go to a simulator every 5th year or so to show that they still have the skills necessary, they still know how to react in an emergency situation. And of course, as we grow older as surgeons, we may not, react as fast as we did when we were younger. And I think for patients, it's important for patient safety that we make sure that all the surgeons have, the sufficient skills to react when there's an emergency situation like an injury to the pulmonary artery, which can be very dangerous. So I hope that we will have simulators for this and that we can test people on the simulators. Now we have the assessment tool, so we can be very accurate in how to assess. And I think this is the way forward. Again, I think that virtual reality simulation is in its infancy, and I think the software will just be better and better. If you look at the first edition of FIFA, if you play FIFA, I play that with my kids. I remember 15 years ago when the first one was out, it's completely different to the ones you see today. And I'm not sure we can cope with that development, but I'm sure that 5 years from now we'll have more sophisticated virtual reality simulators, and I also believe that they will be cheaper and maybe even computer-based, so that you maybe can have a cheaper software, cheaper edition available for everyone.
Okay.
That's the future in my mind.
Another question came in.
Yes. Does the database for the lab sim contain just the normal anatomical situation? Can you adapt it to real cases as for a pre-op simulator? Well, this is not where we are now. This is a normal anatomical situation. We have a tumor on the model, but it's mainly there for knowing which lobe to remove. It's normal anatomy. But I hope that we will be able to develop sophisticated scenarios so that you can practice how to do sleeve resections, how to exercise some of these difficult situations where you train how to avoid it, to do maybe a double sleeve procedure and stuff.
I think the question is also, do you think you will be able in the future just to take our scanner of this patient, put this into the simulator, and do that exact lobectomy of the next day a few times on beforehand?
Well, now I'm guessing. Now I'm looking into the future without knowing if it will be in that direction. But I think that with robotic systems coming onto the market now, there are now 7 or 8 robotic systems FDA approved this year and last year. There's a lot of technological investment into robots, and with robots come simulation and big data and artificial intelligence. And I think I would think that we would move into a direction where you probably would be able to simulate the surgery the day before using the scan. With a 3D reconstruction, you'll actually be able to do a simulated surgery for this patient. And then when you come into real surgery next day, you're prepared. And I think this will be integrated into robot. That would be my view on this. I think robot simulators, 3D reconstruction will probably, in the ceiling green, which is already available. I think all these modalities will be integrated into
Okay. Any other questions? Maybe not really.
So, what do you think about contraindications for vasculectomy? Well, I certainly think there are contraindications to vasculectomy. Saying otherwise, I think is wrong. But again, this is very dependent on your skill level. I think in the beginning of your learning curve, there will be a lot of contraindications. There will be a lot of vasculectomies you should not perform. You should do open lumpectomy for these patients. But if I look at our own perspectives, we've performed now more than 3,000 vasculectomies in Copenhagen. So we have few contraindications now, but one of the contraindications is the size of the tumor. So if it's a 20 centimeter tumor, you're not able to bring it out without using a red spreader. And it doesn't really make sense, I think, to do a vasculectomy if you put in the red spreader again. At least it's not a vasculectomy by definition. Then there are the central tumors requiring a possible sleeve or double sleeve. We still schedule these patients for open surgery because we find it more important to avoid an pneumonectomy and to do a double sleeve. This seriously affects the survival of the patient rather than performing a VATS procedure and risking to do more pneumonectomies because that's the easy way out of the procedure. I am aware that there are some high volume VATS surgeons around the world, especially in China, that are doing lots of sleeve resections, double sleeve resections, very advanced surgery, which is very impressive, I think. But again, I think this is for the minority of surgeons and for very, very high volume surgeons. And I think that is very important to consider your contraindication for vasculectomy, because it's all about, I think at the end of the day, it's all about reducing the complication rate and increasing the survival for our patient, doing the least harm you can.
Mm-hmm. Clear. I think we're out of questions. Do you have any final remarks which we should remember for today?
Well, just one final remark, and this is the surgeon that we train today, maybe the surgeon that will operate on us when we get older. So remember, to be very meticulous with the training and assessment of your surgeons. So that's our future.
Thank you. Thank you very much. What is it? 5 to 7. Perfect. To me, it was a great ESTS webinar again with a very interesting talk and not that many questions, but very interesting, interactive. Also to see that not many people had more than 50 lobectomies done, but everyone agreed, or most of them, that you should have done 50 before we started alone. We had about 40 live attendees. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Petersen, for the webinar today, Medtronic for sponsoring, and you, of course, the audience, for the interest. I hope to see all of you within 3 weeks in Dublin. And we are already busy preparing the webinars series for next season. Thank you very much, and I hope to see you all in Dublin.
Thank you.